let me introduce our first speaker for today. We're thrilled to have Ms. Sarah Meyer join us today. Ms. Meyer earned a Master's of Library Science and Information Science degree from Drexel University and a Master of Science in Information Technology Management and Healthcare Informatics from Regis University. With an extensive background in dental practice management, including serving as a librarian to the College of Dentistry at the University of Florida, Sarah draws from a diverse skill set and knowledge base. In 2010, she was appointed to serve as data manager on an interprofessional precision public health work group. The PPH work group is funded by the Clinical Translational Science Institute at the University of Florida, with the goal of creating an institutional infrastructure for conducting PPH research. So please join me in welcoming Ms. Sarah Meyer to the podium to discuss precision public health, the current and future landscape. Thank you, Ms. Meyer.
Good morning. I'm excited to be here with you today to kick off this year's Colloquium on precision public health. Currently, the United States healthcare system is being transformed by a new paradigm that focuses on adding precision to healthcare, with a promise to alter the model from one focused on disease management to prevention. This paradigm has had many names. Rather than trying to arrive at all-encompassing definitions, an understanding of the precision paradigm can be attained by assessing guiding principles. The term precision medicine was coined in 2011 to provide more clarity than the term it replaced, personalized medicine, which was often misinterpreted to imply that unique treatments could be designed for each individual. The National Institutes of Health currently describe precision medicine as an emerging approach for disease prevention and treatment that takes into account people's individual variations in genes, environment, and lifestyle. A precision medicine model requires the intersection of human biology, lifestyle, and environmental factors, genetics, data, and computational science. In 2015, then President Obama announced his intention to fund a precision medicine initiative, describing it as the right intervention to the right patient at the right time, every time. The Precision Medicine Initiative has two components. The first is a short-term goal to intensify efforts to apply precision medicine to cancer. This is being accomplished with clinical trials of targeted cancer drugs and identification of combination therapies, and developing methods to overcome drug resistance. The second component of the Precision Medicine Initiative is a longer-term goal called All of Us. Its goals are to develop a research cohort of 1 million plus volunteers to share their genetic data, their biological samples, their lifestyle and diet information, ideally linked to their electronic health records. The All of Us cohort was pilot testing data collection in 2016 and 17, and currently plans to go live in the spring of 2018. There are many factors that have converged to make now the right time for a precision paradigm. The precision paradigm is being driven by advances in technical analysis tools for biomedical research, an ability to integrate and analyze diverse large data sets, the necessity to reduce healthcare costs by targeting areas of waste, and a reduction in the cost to sequence the human genome. One of the most profound drivers of the precision paradigm is a reduction in sequencing costs. This graph illustrates the reduction in DNA sequencing costs compared to Moore's law. Moore's Law is a long-term trend in the computer hardware industry to double computing power every 2 years. Technical improvements that keep up with Moore's Law are regarded as doing exceptionally well, making this a useful comparison. In 2001, the cost to sequence a complete human genome was $95 million. 16 years later, in 2017, it's $1,000. The potential of precision medicine is massive, and it has motivated new approaches to maintaining health. Precision health sits at an intersection of two lines, one that moves from precision medicine to precision public health, and another that moves from personal health to population health. Precision health is often considered beyond precision medicine. It broadens the scope of precision medicine from target therapies and drugs for cancer to a focus on prevention and wellness for individuals. It exploits the same technologies and advancements used in precision medicine to identify genetic risk of developing diseases and creates personalized prevention plans based on your genetic information. These same tools and technologies are being harnessed by precision health, are being used to usher in a new era of oral health care. Dental care is evolving to a risk-based model which emphasizes individualized, evidence-based treatment decisions based on patients' behavioral and biological characteristics. The precision in precision oral health care will be obtained by applying the emerging risk assessment and diagnostic tools being developed, combined with a better understanding of how an individual's genetic information affects their oral health. Precision public health is another emergent approach in the precision paradigm. Its research methodologies and guiding principles are being shaped through the lenses of thought leaders like Dr. Arnett, Dean of the College of Public Health at the University of Kentucky, who describes precision public health as the ability to discover, validate, and optimize care strategies for well-defined populations. And Dr. Desmond Hellman, CEO of the Bill and Melinda Gates Foundation, who explains that precision public health uses data to guide interventions that more efficiently benefit populations. And Dr. Corey, Director of the Public Health Genomics at the Centers for Disease Control, who describes, for precision in public health improves the ability to prevent disease, promote health, and reduce health disparities in populations. And Dr. Hugh, an epidemiology professor at the University of Florida, who describes that the precision of precision public health relies on who and where public health interventions and resources should be focused and what risk factors require interventions. And Dr. Desmond Hellman, who describes that precision public health requires robust primary surveillance data, rapid application of sophisticated analytics, and an ability to track geographic distribution of disease and the capacity to act on it. And Claudia Williams, the former head of the Information Technology Department at the White House, who describes that precision public health initiatives share three qualities. They tap into data and technology to reveal solutions. They break down barriers to cooperation, and they enable new partnerships. And Dr. Corey, more accurate methods for measuring risk, behaviors, and susceptibility could provide better assessment of population health and development of policies and targeted programs for preventing disease. Precision public health requires interdisciplinary expertise to layer, integrate, and analyze data from multi-level sources to identify at-risk subgroups to target for public health interventions. Our Precision Public Health Work Group has identified several necessary components of precision public health interventions. The first one is to identify and collect data to define at-risk subgroups. So some of the data source examples that we have determined need to be collected are health-related information, such as electronic health records, electronic dental records, wearable sensors, genetic information, and app information that it's health-related, in addition to geographic information that should be both at the census tract level or the zip code level, and surveillance data such as disease burden and healthcare utilization, environmental and social determinants of health data, and demographic data. During the data identification and collection phase, our Precision Public Health Work Group developed a selection criteria for our data, which was federal, state of Florida, or University of Florida data sources that could be applied to precision public health research in our community, Alachua County. These data sources were then collected, annotated, and organized by topic and jurisdiction, and published on a publicly available library guide. The URL is on this slide. This is an image of the library guide, including the topics. We have several different topics. We've got agricultural, demographic, environmental, clinical data, disease condition and surveillance, housing, legal and law enforcement, just to name a few for you. So precision public health research integrates this diverse data to identify communities by their burden of disease and environmental and social factors. It then analyzes the data to determine associated risk factors and to develop evidence-based targeted interventions. The following is a basic example of how precision public health can be applied to a dental public health issue, periodontal disease. According to the CDC report, 64 million adults over age 30 have periodontal disease. Imagine recently you read 2 articles that have piqued your interest about subgroups at high risk for periodontal disease. The first article introduces a conceptual model of a small number of modifiable risk factors that impact the likelihood of developing chronic periodontal disease. The risks are cigarette smoking, poorly controlled diabetes, and lack of dental care utilization. The second article you read is a study that integrated medical, pharmacy, and dental insurance claims for patients newly diagnosed with diabetes. The study found that those patients who had a periodontal intervention, on average, had a $1,799 healthcare cost savings over a 2-year period, compared to those who received no periodontal intervention. The information in these 2 articles has compelled you to identify a subgroup in your community at high risk for periodontal disease. You wonder if there is a geographic location in your community with a higher burden of disease. The first tool you use is 500 Cities. This tool provides city and census tract level area estimates for chronic disease risk factors, health outcomes, and clinical preventative service use for the 500 largest cities in the United States. First, you look at the measure for visits to a dentist or dental clinic among adults aged 18 or older in the last year. Typically, in the United States, the median rate for this measurement is about 70%. For Gainesville, Florida, in Alachua County, you note an area in dark blue with median rates of 18 to 43%. Next, you look at the measurement for current smoking, noting results higher than the national average in the same location as low dental service utilization. You also evaluate adults diagnosed with diabetes, which reveals 2 potential census tract areas with rates much higher than national averages. The measurement lack of health insurance reveals a similar trend in geographic location to the other measurements you've identified. Next, you go to the NIDCR's data by topic page and select periodontal gum disease. For periodontal disease, the National Health and Nutrition Survey, NHANES, has a data set of periodontal assessments. You decide you would also like to identify additional social determinants of health data. You evaluate a recent community health needs assessment report. One of the tools used in the report is a socioeconomic rating system, which layers poverty, employment, income inequality, education, and health indicators, and scores communities 0 to 100. 0 is for low socioeconomic needs, and 100 are for high socioeconomic needs. Evaluating the index for the zip codes in Alachua County, you note zip code 32641, which is where the majority of the measurements from 500 cities were indicating a burden of disease. The index rating for this zip code is 95. In the Community Needs Assessment Report, you also note populations with no high school diploma are slightly higher in the county overall than the national average. With multi-level data sources identified and collected, Precision Public Health utilizes interdisciplinary expertise to integrate and analyze data sources and identify communities with a high burden of disease and risk factors. The second component of interventions we identified was to enhance community knowledge and attitude and education. Most typically would be similar to health literacy. So health literacy encompasses knowledge, motivations, and competencies to access, appraise, and apply health information. To be effective, health literacy education must be appropriate to education level and sensitive to language and culture. Your data analysis results can also be utilized to develop targeted health education campaigns. While there are many personalized interventions for periodontal disease, oral health literacy is a broad intervention that can be applied to populations. A recent study indicated periodontal disease can be improved by oral health education on topics such as dental terminology, periodontal disease, oral hygiene, smoking, and diabetes. Those with higher oral health literacy had on average 2 additional teeth, 5.5% fewer bleeding sites, and 9% less plaque. So our work group also identified some objectives that we wanted to work on, and one of the first ones was to identify relevant university-wide programs to develop an infrastructure for precision public health. So thus far, we have identified 5 areas of disciplinary inclusion, and they are big data science, community engagement, health system engagement, data resources, and communication sciences. And recently, we also presented to our Florida Department of Health and invited them to participate in our work group. It's taken some time to really hone the right interdisciplinary mix for precision public health. Third intervention component is community organization and engagement. Community engagement is vital to reducing health disparities and to increasing participation from diverse populations in clinical trials, to ensure that everyone benefits from precision medicine and precision health therapies and interventions. One of our clinical translational science programs at the university focuses on community engagement with a program called Health Street. Health Street has 9,000 members, and the demographics mimic our community as a whole. And it utilizes focus groups and town hall meetings to assess health concerns from the community, connect people to health services and opportunities to participate in relevant research. And it also increases community trust in research with meaningful collaborations. Community trust and participation is critical to the success of precision medicine and precision health, which depend on a population-based approach. Data collection from large, diverse populations is necessary to identify similar individuals for comparisons, to identify subgroups who respond differently to interventions, and to provide comprehensive assessments. So how are we doing in this area? In 2009, 96% of participants in genomic-wide association studies were of European ancestry. And by 2016, this figure was 81%. It was really only due to some genome-wide association studies that had been performed on Asians, and all of the rest of the underrepresented populations, the statistics remained the same as they were in 2009. And so the authors of the article, Genomics Failing on Diversity, explain that if this imbalance doesn't improve, some populations will be left behind on the road to precision medicine. Additionally, we identified 3 other components of interventions. I won't have time to review them, but I want to just let you know about them. They're assurance of personal health services, environment, housing, food, water, nutrition, physical activity, smoke-free air, and leadership, policy development, and administration. So another one of our work group objectives was to create methods to overcome the challenges of conducting precision public health research. When our work group first convened, we only had 4 members from 3 departments, so we spent a lot of time sharing with each other our interdisciplinary viewpoints on precision public health. And we had question and answer sessions, and the first question that we asked was, in your field, what are the challenges of precision public health? So I've identified some of the top challenges that were reported by discipline. For bioinformatics, one of the top challenges is minimizing selection bias. And for epidemiology, there's a large concern with how the impact on effect size is using machine learning versus traditional linear models. And for biostatistics, the challenge is lengthy data application processes, such as review committees and IRBs. And for geography, a lack of social determinants of health in patient data is a large challenge. And for everyone, the availability and access to relevant, high-quality data sets is a challenge. Another objective was to develop an educational initiative to increase precision public health research. We're doing this with 2 pillars, grants and internships. So our Clinical Translational Science Institute and Informatics Institute offered the first RFA for precision public health last month. And we're excited about this in the work group because we also will be reverse engineering the case studies to try and develop a how-to primer for precision public health research. And our first internship was in the spring of 2017. And the aim of that internship was to develop a case study through the examination of the sources on the library guide to identify a subpopulation at risk in Alachua County, and then to also document the research methods and challenges, because precision public health research is mostly in uncharted territory, and so having that documentation really helps us to understand more about what we need to offer in terms of new tools. This is the research poster from the first internship case study results. And 2 at-risk subpopulations were identified using the open source data. The first was African American women ages 35 to 65. And the second subpopulation was divorced, separated, or widowed persons of any race, age, or gender. And the commonalities that both these groups had was that they were either insured with Medicaid or uninsured, and they were more likely to be diagnosed with all three chronic diseases, hypertension, obesity, and diabetes, than their peer groups. Our internship in 2018 is to develop an integrated workflow using the R computational platform packages and to help other researchers be able to document the process that they take as they develop their own precision public health projects, and then also to determine the challenges and feasibilities of precision public health research. So our interns' challenges were similar to those of the work group, and they were lack of data sharing, and privacy and trust were issues with data sharing. Paywalls, so a lot of the open source data that was available has gone behind paywalls, and missing values and variables which affect the way that they analyze the data. And then also a lack of data transparency. So if you're trying to compare data collected from previous years with data collected now, sometimes the methodologies have changed, and that will affect the results. Additionally, Dr. Hugh, the epidemiologist in our work group, was awarded an American Heart Association grant. For his grant is called the Total Environment and Hypertensive Disorders of Pregnancy, a Precision Public Health Approach. And this research will determine associations between the natural, built, and social environment factors and hypertensive disorders of pregnancy. And uncovering these associations, he'll be able to build predictive models of risk factors and develop an app to provide individual level risk factor identification and recommendations to reduce risks. The future landscape holds many opportunities to addressing the gaps in precision public health. To benefit from electronic health record data, we must abandon data silos. We must develop methods for electronic health record interoperability and integration of detached records, such as medical and dental records, sensors, apps, and identify methods to increase data sharing. I was excited to see that the Precision Medicine World Conference will be focusing a little bit on this topic this next session. Dentistry is better poised than medicine to achieve electronic health record integration and interoperability, and this is due to the number of vendors and electronic health record products that are available. For medicine, there's approximately 1,100 vendors that offer an electronic health record product, and that figure has twice the number in 4 years. And for dentistry, there's approximately 4 major vendors that offer an electronic dental record. And realizing interoperability is going to require vendors to collaborate and build a standardized communication format. We also need dentistry to be better integrated into the overall health system. Poor oral health is linked to diabetes, adverse pregnancy outcomes, heart disease, reduced quality of life. Yet oral health is an isolated and often too neglected part of healthcare. It will be necessary for dental professionals to continue to develop collaborative partnerships and identify opportunities to emerge as oral health primary care physicians and to integrate into the evolving healthcare system. A recent journal article introduced a conceptual model identifying several primary care interventions that could be addressed by oral health care physicians. A few included undiagnosed diabetes, sleep apnea, and management of facial lesions. Data privacy is a prominent challenge for all of the researchers in our Precision Public Health work group. This challenge is not driven by technology, but rather by social concerns from patients about who has control of their data, rightfully so. While the public debate continues about genetic privacy, one opportunity may be to research the public's positive relationship with the use of their dental records as a means of identification. Another method that has been proposed to increase data sharing is patient ownership of their data. Early studies show patients with complete access to their health records have higher health engagement. Right now, this type of access is rare. Providing this type of access to citizens may also encourage quicker development of interoperable electronic health record systems. The NIDCR launched a strategic vision initiative to advance dental, oral, and craniofacial research. There are 5 goals to meet by 2030, and 2 are directly tied to the precision paradigm. The first is precision health, both for individuals and populations. And the second is oral health being fully integrated into overall health. The next steps for our Precision Public Health Work Group are to advance data sharing and evidence-based targeted interventions, to refine our research methodologies, engage our community education and partnerships, to work together to achieve precision public health. The power of bringing together the right people in the same room can be significant. It provides an opportunity to listen and learn from each other, everything we can about the issues, and develop solutions. We have an extraordinary opportunity over these next 2 days to listen, learn, and share with each other how we can advance precision public health in dental public health. Thank you.
That were not on the slides is this simple little word called poverty. And when I think of looking at the geographical map, I'm assuming that that's where the poor people live in that particular county.
It is.
And
yes.
they carry the burden of disease, and then you fill in the blank which disease in that area. When you're matching previous data with current data, how do you weigh poverty as opposed to smoking or drinking coffee? It just seems that it's such a major social determinant to health outcomes and distribution of disease, and somehow the emphasis to either minimize or reduce poverty would seem to give, from a societal point of view, a greater bang for the involvement. What do you think?
I absolutely agree, and I think that we have to, as a community, engage to address as many of the social determinants of health inequality as we can. Poverty is a large one, and really try and work together as a collaborative group to see how we can address that. We tend to focus more on the health outcomes, but it is very, very much tied to it. And I was so pleased when I found that socioeconomic index, because it did layer in data that included income inequality. And in Alachua County, we have one of the largest disparities between income inequality. And so we do notice that it does end up in that. That's part of our eastern side of our community. But it's also important to look at other areas where inequality may not be as obvious. Thank you.
I'm interested, just recently in the last couple of days, first let me back up. I love the speech, thank you.
Thank you.
E-cigarettes.
Yes.
Just a number of products. I mean, we could go with the salt in our diet, we could go with the sugar, we could go, I don't hear that.
Oh, I think
when we're talking about, I don't hear that side of the equation.
Yes, absolutely. Lifestyle and diet information is very critical as well, and that's part of what all of us will be evaluating. Is the volunteers are hopeful to contribute not just their genetic information, but their lifestyle and diet information so that we can really help to identify some more of those risk factors. Some of them we know, cigarette smoking is an obvious one. We also know we should reduce salt and sugar and other things in our diet. But it will be, I think, very beneficial when that data can fully describe that for us.
I didn't make my point clear.
Oh, sorry.
I'm talking about the corporate sector.
Oh,
I'm
absolutely.
talking about the incredible pressure to smoke, to
Yes.
eat salt, to fast foods. I mean, they promote going to breakfast at
Yes.
fast food places. It's that I'm not hearing about. I understand the personal responsibilities to that, but oh my gosh, their budgets for Coke are incredible marketing budgets.
Absolutely.
And I'm not hearing how we address that in public health.
I think what's exciting about precision public health and as it moves into oral health is that we have an opportunity to start being collaborative partners with the entire community of health providers and really try and hone down that precision of what we can deliver to the population to help them and educate them on understanding what those risk factors are and ultimately what they lead to.
One more comment. San Antonio just 2 weeks ago increased the age to purchase cigarettes to 21. We're the first state in the first city in Texas to do that.
Excellent. Now all we have to do is eliminate them.
That was a great presentation. I
Thank
was
you.
particularly taken with your point regarding the more European base of data coming out of genomic studies. And I'm curious to know more about what is happening, particularly in the United States. I don't propose to speak for the African American community, but I can tell you that there is still great trepidation
Yes.
over some of the previous misuse of data
Absolutely.
in that community because of past history.
Absolutely.
So much of that genetic code is interlinked with other population sets. And there is this distrust of, and I feel this often, just because I'm paranoid doesn't mean they're not after me.
No.
And so
Agreed.
there is this concern about safety in a community that is so beset with other threats and challenges that are really quite real. So I'm assuming that is going to continue to be a major hurdle and challenge. Can you talk more about how that's being addressed?
I agree with you, and in a lot of my research, when I came across that was one of my largest concerns because I feel that precision public health really, and precision medicine, precision health, it needs to be for everyone. And so without us addressing that, I feel like we're creating possibly a model that will just be, for instance, for people that have a lot of money to buy cancer drugs that cost $100,000 a pill. And so it has to be our goal to move away from that model. I also, I didn't include it in my presentation. I cut it for thinking I would not have enough time. But part of what is happening is as we don't have enough genetic information that we've gathered on diverse populations, we're actually misidentifying genomic variants. So this happened with hypertrophic cardiomyopathy. And there's a common set of variants in African Americans that we had misidentified as variants for hypertrophic cardiomyopathy. And so they went through all the planning stages and developed risk assessment plans, not just for the people that were diagnosed, but for their families. And then all of a sudden, researchers went, wait a second, this isn't right at all. These are all just common variants in the African American population. So I think we have to understand that if we can't move it that way, we could actually be making information that is not accurate, that won't help everyone. And so I think what we can do is be stewards of being very safe and careful with people's data, but I believe ultimately in the model that I presented, which is that patients own their data, because I feel like if you own something and you want it used, and you can look at the research that it would be used in, and you feel it's an appropriate area, at least you feel that you have control over how that will be used. There are a number of still issues with that, but I think we have to look at different models for how we can increase data sharing to make sure that we are not leaving people behind.
Again, thank you for a terrific talk.
Oh, thank you.
I wanted to follow up on Dr. Evans' very important point about reluctance or concerns of having one's genetic information available. And I think it applies well beyond any one particular group of individuals in a political, economic, and policy environment where having a pre-existing condition can
Yes.
make you either ineligible for insurance for health or have you be categorized as being in a higher risk pool and being allowed to have that insurance carrier charge that
Yes.
person huge amounts more for insurance. I would think that no one would want their genetic profile, meaning their risk profile, meaning their likelihood of getting a condition, be available to anyone but themselves for fear that they would be discriminated against, irrespective of race or ethnicity, but discriminated against based on their risk profile for various medical outcomes.
And
So,
those are the barriers that we have to break down, because our genetic information is very important, and it'll be important to sharing that information so that we can understand better how to address these risk factors and reduce these disease burdens. So I completely support ideas that insurance companies are not allowed to do that, and neither are employers, because people have concern about their genetic information being released that way as well. And so we have to look beyond a model that penalizes people and develop a new one.
I would like to follow up on this point. I believe there is a regulation called GINA, standing for Genetic Information Non-Discrimination Act, that prevents insurance and others to do that. However, on the public's perspective, you cannot eliminate that. I think it's a natural concern. I wanted your opinion about the, and you mentioned, and I agree 100%, that they're not good data sets right now, or they're not complete or valid or accurate or representative.
Right.
However, there's a model where people actually pay to have the genetic data analyzed and matched with behavioral and other factors, the commercial factor, the corporate.
Yes.
And these companies, I hear now they have close to 1 million or more genetic data sets superimposed with not only geography and lifestyle, but location, internet searches, behaviors, and others. What is your just thought on that currently unappreciated emerging?
Well, I'm excited that people are interested in having their genetic information analyzed, but sometimes I feel like they don't analyze the privacy policies of what will happen with that data, and so then they're surprised when they hear that that's what's happening with it, it's all being integrated, and then there's concerns about how that data will be shared. So I think that one of the most important things we can do is try and help people understand that there are actual health reasons that if we share our genetic data in responsible manners, that can help society as a whole, and try and move away from a model that's commercial based to a model that really is incorporated into our healthcare system. And so that we all understand that our genetic information is not bad, it's not negative, it is who we are, but that information that we carry can also help others. And so just a broader understanding of that isn't just honed down to maybe where our ancestry is or what we search for online, but a much broader picture.
A comment rather than a question so much, and this is going back to Hal's concern about addressing poverty issues as a major determinant in this, and your answer to him in that most of what we study is sort of the health outcomes of that. I had an opportunity, I was at the University of Kentucky, to interact with a fellow named Jim Ziliak, who directs a major federally funded poverty research center. And when we went to talk to him, it was striking how little we at the outcome side of things really understand the aspects of multi-generational community and family poverty, behaviors,
Yes.
barriers, choices that they have to make.
Yes.
And I think we need to do a little bit more work in understanding that side in driving these outcomes that we're looking at if we're going to have a change in the process down the road.
I completely agree with you. We have more work to do.
Thank you for a great overview. I have two concerns. We talk about data all the time and collection of data and sharing of data. What I haven't heard, and my biggest concern, is interpretation of the data.
Yes.
That one is something that unless we know how to do that correctly, the data is going to be detrimental.
Absolutely.
So that's number one. Number two, you also talked about, and you mentioned association here between oral health and systemic conditions. Who determines the precision and the accuracy, and it's a softball for a librarian, about the publications that are coming out there?
Mm-hmm.
You mentioned GWAS as an example. Well, 85% of systematic review of GWAS is wrong.
Yep.
So who is the person, the group, the individuals that will enable us to use, interpret, and assimilate and analyze the data correctly? Because unless we do that, it's going to be very detrimental.
And I believe in our work group, we've identified a lot of those challenges you're talking about with integrating and analyzing data. And sometimes you get in and you've collected all this data and it still doesn't have anything that's relevant. And you have to look at if we're even using the right information. And so we have to be very careful with that. It's not just all about data, because data is people. And I think that in your discussion about what kind of people can help us with that, we've really found it's going to take an interdisciplinary approach, because I'm not an epidemiologist, so I can't tell you all of the ins and outs of how I should analyze that data. I can tell you good literature and proper control of that, and making sure that we get good published results. But that's a whole nother presentation as to the problems with that. And you mentioned the systematic reviews, which is a whole nother ball of concern.
Hi.
Hi.
Thank you again for a wonderful talk. I wanted to come back to the issue about diversity.
Yes.
And in terms of genomics. I have heard from somebody at 23andMe that companies like 23andMe and Ancestry.com actually are getting pretty big diversity, particularly with African Americans who want to know something about their heritage. But one of the problems is not just the sampling and getting enough people to participate, but it's also when you do the genomic analyses, if you have someone who has an admixture of heritage, it's more difficult to tease out the components than if you start with Africans who move to the U.S. who then want to get their genome scans and things like that. So there are also some technical issues that are involved. Mm-hmm. But there definitely are major concerns about representativeness and generalizability of a lot of these issues. I also wanted to come back to the question that Dr. Slavkin had about poverty and ask you a question about the index that you used.
Yes,
is that an index that you developed, the social needs index, or is that one that you found and then applied to Florida? Is it only applied to Florida data, or is it available?
Mm-hmm, it is available. I can get you the information on it. It's a proprietary algorithm that was created, but it is used across communities.
Okay. Because I've seen in the UK, they have a social deprivation index for communities. And they've used that quite a lot for, probably a decade and a half in their various papers. And then I've also seen Nancy Krieger and her group particularly in Massachusetts and Boston, looking at a lot of different measures of
Yes.
poverty and social deprivation, and often they come up with if you just use poverty,
Right.
you get about 90 or 95% of the signal that's there, and adding all these other ones may be a lot of effort for not that much,
Right, not much
return.
gain.
So I'm wondering how this index would compare to a simple use of percent of federal poverty level or something like
That's
that.
a great question. We could get the index out and give it a try.
Great, thanks. And I look forward to seeing the references and,
Sure.
and checking it out. Thank you.
Thank you.
Thank you so much for your presentation. It was a very good presentation.
Thank you.
Actually, I have 2 different points, if you don't mind. The first one, it's my notes from the presentation that I know that this is a very difficult task to do, to reach the population level and try to assess risk and determine the precision of public health for the population level. But I noticed that there are so many sciences that has to be integrated to work on, to take the task and make it work. And all of them are very big and huge and detailed. Like for example, environmental health risk assessment, which really and this is part of my specialty when I did my graduate school, that focuses on the environment and risk factors, chemicals, how they affect people, and integrate in the get into the system and change the biology and all that. So this is mainly environment, and go to the chemicals in soil, water, and all that, food you eat and otherwise. For the health policy, it's more the policies, health insurance, and etc. And then you come to the economics, where you have all the economical issue. Poverty is probably part of that, and then you jump into bioinformatics and genomics. I think that, I might be wrong. There is no cross communication between all of these big, huge disciplines in a way that you can put them in one model. It's extremely complicated and difficult. This is.
It is, and that's part of what our work group is trying to analyze, is how feasible it is to do. And also, though, I think it's important to realize that like you're saying, all these factors come together, and so we have to start looking at them under one umbrella and start addressing all of them and not just isolating them out, where we've put dentistry over here in this little corner and we've got this over here. We need to really start integrating and looking at how we can do that. So you mentioned environmental wide association studies, and when we looked at that, when Dr. Hugh was preparing his research proposal, I think we identified that there were only 3 that had been conducted, and it's such a much, much broader field and very important to things we don't even know yet. So I think we're just in the discovery phase of precision public health. And so as we decide and figure out better methods to use, then that will help to create the tools necessary to make it a simpler process to be done. The All of Us research cohort envisions a type of a database where a practitioner can literally sit down and type in the type of patient they have in front of them with as many of the different risk factors and identification areas as they can, and then have that database return to them similar individuals. So that would be an amazing tool. And so we have to really just keep looking at how we can move this.
Thank you. The other point, it might be a little bit not as important as the previous ones. Everybody mentioned, when they mentioned the ethnicity, they mentioned their genomic background. I would say even the ethnicity will tell something about the culture. We see that the U.S. is becoming more diverse, and the more refugees, immigrants, people from different countries. They have the culture. I know the culture affects the health, and probably I noticed that the first generation and second generation, they have very broad perspectives about their health and health behavior. So I think it's very important to integrate culture as part of the health, and specifically when you compare people from the same house but first generation, second generation, how they affect the health and health approach. Thank you.
Yes, thank you.
So that was a great presentation. Thank you again, Sarah Meyer. Let's give her a round of applause.